We're now proceeding to an exciting and evolving frontier, interventional procedures in obstetrics and gynecology. Let us welcome Dr. Manish Kumar Yadav to share insights on the techniques that are transforming both the diagnosis and therapy in the field. Dr. Manish Kumar Yadav is a senior consultant, neurointerventional radiology imaging and interventional radiology, KIMS Health. Welcome, sir. Over to you.
Thank you. Thank you, Jay Krishnan sir, for inviting me for this talk. So basically, this talk will be covering what intervention radiology is helping our gynec and obstetric colleagues in treating a lot of things which were considered to be very difficult in the past. So this talk will be focused on two groups. One is the women's health, and then of course on fetal health. The majority of the talk will be on vascular interventions, what we do, and then briefly touch upon the fetal intervention, which we do in collaboration with our fetal unit. So we all know about postpartum hemorrhage, and the nation talks about it, the government talks about it, and it is one of the quality indicators of healthcare is how much is the maternal mortality. So one of the major causes is postpartum hemorrhage, which remains a later major cause, and how much we are able to prevent indicates towards how good our healthcare system is. What are the potential causes of PPH? We all know about it: uterine atony, retained products, placental anomalies, uterine inversion, rupture, lower GI tract, genital tract laceration, cervical pregnancy, vascular malformations, and coagulopathy. If you see, a lot of them are traumatic, and but there is a significant proportion which are kind of vascular related, and that's where the vascular intervention comes in. The surgery has been there traditionally, and probably for a long period of time that was the only option which was available. So it faced challenges such as the failure rates were reasonably significant. Then coagulopathy was another challenge where things may get rapidly worsen, and there were always an option problem of post hysterectomy failures. So why ligation fails, or why internal iliac ligation or uterine artery ligation or even hysterectomy fails is because of the collateralization. So this is what a typical arterial tree looks like. Internal iliac artery gives rise to uterine artery, and then it gives rise to other pelvic branches, and one of them is middle rectal artery, which actually anastomosis with something called a superior rectal coming from the inferior mesenteric artery. So here lies the anastomosis. So when we ligate the internal iliac artery, what happens is this flow stops bilaterally, but what continues to happen is through this anastomosis, superior rectal to mid rectal, and then the blood continues to flow to the uterine artery, and it results in failure of ligation. Another challenge is the ovarian arteries, which also comes and continues to feed to the uterine artery. So these are the causes why circulating causing an arrest of the internal iliac artery sometimes fail to arrest the bleeding. So we have to look at something which is something different and overcome this challenge. So what we do is embolization. So what we do in embolization is deliberately block the blood flow to the vessel using an endovascular route, using either solid or liquid agent, and to have a therapeutic result. It has been there for a long time, embolization, and it was used primarily in control of pelvic hemorrhages in malignancy, trauma, or radiation results. And then what were the major particles or agent what we use is gel foam. This is a gel foam. We all are familiar with gel foam. PVA particles. The name is polyvinyl alcohol, but actually it is a solid particle agent. Then we have coils. Then we have something called as balloons, and then NBCA. NBCA is basically a liquid agent or glue, what it's commonly known as. So talking about why embolization, because it's safe and effective procedure with survival rate reaching close to 90%. And it also offers fertility preserving options. We are not removing the uterus or removing the chance of future fertility. Advantages, it's a local, the procedure can be done under local anesthesia, preserves the organ. It can be performed in extremely unstable patient. It can be repeated if it is required. It can treat lesions or injury into the vagina, cervix, and uterus. And it can also be performed in the presence of coagulopathy. So, coagulopathy is not an contraindication to perform this. So, basically, what we do in embolization is take a catheter, reach it into the uterine, and inject the particles or gel form on the desired therapeutic effect. How different it is from ligation or coil embolization? So basically, if this is the internal iliac artery, you ligate proximally or deploy a coil proximally. What happens is the distal bed continues to fill through the collaterals. Whereas if you use a particle, the particles go and travel and they get trapped at the smallest distal level. They get trapped in the uterine bed, and that's why the effect of collateralization is not there. So even with so much collateral circulation, it helps to arrest. So the particles are the preferred choice of agent for embolization. So how we do it is basically go from one side, embolize the uterine artery with the particles, then take the catheter back into the ipsilateral side, reach there on the ipsilateral uterine artery, embolize it, and then do an angiogram and see if any other collaterals are there, then we embolize those also. What are the major causes is atonic uterus, bleeding diastasis, DIC, or jaundice, vascular injury, and vascular malformation. This was a case of atonic PPH, 27-year-old. She had vaginal delivery, persistent PPH. This was a hypertrophied left uterine artery, and after embolization, we blocked the entire bed. And then we go for the right uterine artery. Again, we see a lot of vascularity there, we block it. So basically, the technique works only if we are able to do bilateral. The unilateral is, if we are not able to do bilateral, there are chances of failure. So in this particular case, the bleeding stopped and she was discharged 5 days later. Another challenges which obstetrician and gynecologists face is a bleeding diastasis, where it is a challenge to operate in such patients, and once they get into the bleeding diastasis, then things go out of hand pretty rapidly. This was a 23-year-old with high bilirubin, massive PPH, and PT was prolonged more than 40 seconds in spite of 6 units of FFP. So then on the angiogram, we could see some blush. We can go there, go as distal as possible and embolize it. Repeat it on the opposite side as well, and devascularize the bed, and then the bleeding stops. So bleeding stops, and once the bleeding stops, all the other parameters kind of start improving. And she was discharged 3 weeks later. Another traumatic events where particularly is a challenge where when local examination or local control is not possible. This was a case of assisted vaginal delivery, developed PPH, then hysterectomy was performed, and after that she continued to bleed. So she came to us, we could see a pseudoaneurysm here. That's when we enter there, and we injected glue. So most of the time, if coagulopathy is present, we tend to prefer to use glue rather than just particles, especially if we find any focal pathology. If we find a pseudoaneurysm, we go and use glue. Another patient who had a post-hysterectomy PPH. So again, here we can see a pseudoaneurysm here. We can reach there and embolize it. In this particular case, we used coils. Post episiotomy PPH, again, if we see a particular site of bleeding, then the job is simple. We just reach the site of the bleeding and embolize it. Here again, the glue was used. One of the causes for delayed PPH is pseudonism or AV fistula or AV malformation, which are pseudonisms are mostly secondary to infection. So this was another lady. After 3 weeks, she had presented with bleeding. That's when a CT angiogram was done, which showed a pseudonism here on the left side. This was the pseudonism. And as it was picked up on the angiogram, we entered the uterine artery, we could see the pseudonism. Then we injected glue. The glue completely embolized the site of injury. Coming on to vascular injuries, this again, the bleeding, this particular patient, 29-year-old, started bleeding 2 weeks after cesarean section. An ultrasound showed a pseudonism. As we do with pseudonism, enter the uterine, reach H much distal as possible, and inject glue. It's in pseudonisms, it's important to trap both the front and the back channel. Otherwise, they tend to refill through the collaterals. AV fistula. So this was a patient who was 24-year-old, massive episodic bleeding. 6 weeks post CS, and ultrasound showed a vascular malformation. So how we identify it's a AV fistula is filling of the veins. If once we inject the artery, if we see a venous pouch or the veins filling simultaneously, it is a sign of AV fistula. What we see is a lot of draining veins there, so it is a fistula. And for fistulas or high flow vascular malformations, glue is the best agent what we use. So we enter the site of AV fistula and then inject the glue. The glue will tend to take out the venous sac as well as the outflow veins. This was a pre-embolization and this was a post-embolization. Now we can start seeing the normal vessels filling, and now we don't see the veins filling. And she was discharged 48 hours later. So more dramatic the arteriovenous connection is, more dramatic is the result of occluding the fistulas. Vascular malformation, this was a 32-year-old presented with delayed PPH 4 weeks after LSCS, and this was a uterine AVM. So what we do is we enter there, enter with the microcatheter and inject glue. In high flow conditions, as we discussed, the glue works the best. So this was the previous before embolization, and this is after embolization. In AVM or very focal pathologies, we need not do bilateral. Even unilateral is enough, provided we are able to embolize distal to the pseudonism or the communication channel. Many times the uterine AVM is confused or is always one of the differential is one a retained products or a trophoblastic tumor. So this was a patient who presented few weeks after abortion delivery with bleeding, can have underlying cholangiocarcinoma or retained products. So how do we differentiate them? So angiographically, both of them look similar, arteriovenous malformation or underlying placental tumor. So that's where the serial beta HCG helps. If it is high, then we know it is something to do with the placental tissue. Briefly about uterine fibroid embolization. Conventionally, all these were being treated by myomectomy, laser myomectomy. There were a lot of choices available. Open, laparoscopic, laser, histoscopic, hormonal therapy, and then uterine fibroid embolization, HIFU, high intensity focused ultrasound. And then recently there are papers on percutaneous thermal ablation. So how do someone choose among all of these? So where does UFE stands is currently UFE has a large series now which has expanded over a lot of patients, and Even the long-term data is available. How are the clinical outcomes and which symptoms tend to do better? What is seen is overall symptoms of menorrhagia or the bleeding symptoms are the most ones to respond. So if the patient has menorrhagia, probably they will be benefited. The results are in the range of 80 to 90%, depending on the studies and what particles were used and when the study was done. So as the procedure has refined, the results have also improved. How about improvement in pain and pressure? These are like kind of little less responsive. So the response is around 60 to 70% in such symptoms. Leiomyoma reduction, size reduction happens over a period of time. We don't expect it to drastically improve in first few months. It will take a longer time, and the larger tumors will take larger fibroids will take a longer time. Incidence of hysterectomy or as a treatment for complication of UFE is incidence is very low, less than a percentage. As far as procedural cost is concerned, the data is the cost is approximately same. This is from the Western literature. It is not from the Indian literature, but overall costs are lower because of the lesser hospital stay. Which are the candidates who are good for UFE versus other procedure is the ideal patients is fibroid size less than 10 centimeter or the uterine size of less than 20 weeks. More than that, probably they may benefit better from a hysterectomy. So how do we select patients is based on MRI. So we do MRI for almost every patient and it has to be a contrast MRI. We want to look at the morphology of the fibroid, location of the fibroid, and we want to, of course, rule out sarcomatous change where embolization is not a treatment option. So the fibroid located within the myometrium and not projecting out of it. So the pedunculated fibroids are especially no-go, so where we don't offer UFE. And we consider alternate procedures when there are small pedunculated fibroids or submucosal fibroids with narrow attachment. What happens is some mucosal fibroid they tend to get expelled out, and the pedunculated ones they can get detached and they can become free. And probably other treatment options are better. So this is one where we don't do is pedunculated with a small pedicle, less attachment to the myometrium. And then within the when they have a smaller pedicle, that's where we avoid going for a embolization. So what is the goal of the treatment is achieve infarction. Technique is uterine artery. We go through the uterine vessels, embolize both sides as we discussed from the embolization. Post UFE outcomes, reduce in the bleeding, improve in the pressure score. Symptoms, bleeding symptoms are the first one to respond. We want infarction. So these are some cases where baseline and then progressively it reduces. This again MRI showing reduction. Case of cervical pregnancy where kind of termination becomes a challenge because of extreme vascularity. Again, it helps. Pelvic congestion syndrome, chronic pelvic pain, what we see is the reflux along the ovarian veins. And once we embolize the ovarian veins, they tend to do better. The pain significantly comes down. Vaginal varices is another application where we use a balloon and then inject the sclerosant so that it stays in sclerosis. Briefly on the fetal interventions, we do selective fetal reduction in early pregnancy with the diamniotic twins. We use kind of percutaneous, use potassium chloride to achieve selective fetal reduction. We also have fetoscopic laser photocoagulation for twin-to-twin transfusion syndrome in more older fetuses or monoamniotic twins. We use RFA or microwave selectively ablate near the bladder vesicle vessels to achieve selective fetal reduction. Then chorioangiomas, that's where we selectively block the feeder to the tumor. And then what happens is the vascularity comes down and the polyhydramnios is controlled, the fetal anemia is corrected. Then intrauterine blood transfusion, basically we immobilize the fetus by injecting atracurium into the fetal thigh and then go ahead and target the portal vein or the ductus venosus, and there we give the blood transfusion. So intervention, it cannot do everything, but it can do something, and together we can add synergistically and help to change lives. Thank you.
Thank you, Dr. Manish Kumar, for the comprehensive overview at the interventional procedures.